All right, thank you all for being here today. I'm thrilled to have the opportunity to address my colleagues and friends, Jessica Pena and Nihar Desai, here at the National Lipid Association 2026 Scientific Sessions. This is an opportunity to discuss some key elements of interest regarding implementation of the guidelines. And what we're going to do is it's going to be mostly conversational, but I just want to set the table for why we care about this information. My name is Dan Soffer. I'm an internist and clinical lipid specialist at the University of Pennsylvania, and I'm a past president of the National Lipid Association. And in about an hour, I will be the chief science officer of the National Lipid Association. I'm also the co-director of the Foundations of Clinical Lipidology course. Jessica, could you introduce yourself?
Oh, sure. Well, congratulations on being the Chief Science Officer of the NLA.
Thank you.
I'm Jessica Pena. I'm a cardiologist who specializes in prevention and lipids at Weill Cornell in New York.
And Nihar Desai, Associate Professor at Yale School of Medicine and Vice Chief of Cardiology. And thanks again, Dan, for the opportunity.
I'm so thrilled to be able to sit down with both of you. I respect both of you so much. Your contributions to the field, and especially with regard to implementation. So that's going to be the focus of what we're talking about today. Of course, just to set the table, a reminder that ApoB containing lipoproteins, of which LDL is the predominant ApoB containing lipoprotein, are at the center of atherosclerotic cardiovascular disease management. As a matter of fact, I don't know about both of you, but every time I see a patient, I refer to Life's Essential 8, which is a trademarked American Heart Association prompt to talk about how we can have an intervention to optimize the outcome for our patients with atherosclerotic cardiovascular disease. And lipid management is a key element of Life's Essential 8. And when we're talking about lipid management, the parameters can be broad, but we have some general and specific parameters. But ultimately, what we're talking about is trying to enable our patients to have less ApoB containing lipoproteins. And you can rephrase that as lower LDL cholesterol, or lower levels of non-HDL cholesterol, or fewer ApoB containing lipoproteins in the circulation. We have guidelines that give us some ideas about how to manage this care, because everyone's different and we need some rules so we don't have to reinvent the wheel every time a new patient comes into our office. And the guidelines are our rule book for management. They're not perfect. I like them a lot. I have particularly liked the 2026 dyslipidemia guideline, the American College of Cardiology, American Heart Association Multi-Society Guideline on the Management of Dyslipidemia, because I think for the first time in a while, this guideline aligns more closely with how we have been taking care of patients for the last decade or so anyhow, because it really does give us a broader perspective and a lot more latitude, because the science and the evidence has caught up with what we thought the biology was telling us. There's some key elements to the guidelines that I think are really important to focus on. First off is risk assessment. And there's a lot of different elements to risk assessment. And I think we're going to go into some questions about whether we have the right tools in clinic right now for optimizing risk assessment. There's targeting, like, are we targeting the right things? And are we prioritizing our targets in the right way? And then, of course, we have goals of therapy. So I forget which speaker yesterday, made a point at the scientific sessions of, I almost breaking out in song that goals are back, and just the enthusiasm I think that clinicians and our patients have for noting that we now have therapeutic goals again written into the guidelines. We may have had them conceptually in our heads before, but now we have them written into the guidelines. So you're with me so far, right?
Yeah.
I didn't say anything that made you, confused or made you want to run away. All right. So that's just the background that I'd like to bring our attention to. And we're not going to review exactly everything that's in the guideline right now, but I have some important concerns, I think. Well, I shouldn't say they're important. I have concerns about some ways that this is going to be implemented. And I made a list so I wouldn't forget all of them. and we can take them one point at a time. And if we think they're easy, you're like, nope, we got that. Here's this, and then we'll just move on. But be curious, and maybe I'll just go back and forth like a tennis match here. So Jessica, do you think it's going to be difficult for clinicians to classify the risk of our patients, both in the secondary prevention and in the primary prevention realm, using the format that's established by the guideline?
Sure. So I think that clinicians, I think, will welcome having an updated calculator, the prevent calculator, and having guidance about, how to use it. I think there will be a challenge around, being able to do this in the time you have during a clinical encounter, and having it be readily available. We're still waiting for that to be, implemented in the electronic health record. And then I think also a challenge is how to use that information beyond the number to convey risk, convey what that means for a patient, and how you present that information in a way that helps with behavior change, both for the physician, and the patient. And so I think, the calculators is one piece, but I think we still need, more implementation strategies to help us figure out how to use it to help guide care the way we want it.
So, all right. So starting with the primary prevention, then talking about the use of the calculator, Nihar, I wonder if you have any thoughts. Do you think primary care clinicians, or you're both cardiologists, do you do a lot of primary care in your practice? And so do you have experience personally of knowing whether or not primary care prevention patients are going to even want to use a calculator?
Yeah, I think it's a great question. Yes, we do lots of primary prevention in our clinics. Maybe it's a slightly different subset of patient that's kind of being referred to the prevention center or to the lipid clinic. But I think to Jessica's point, we had gotten accustomed to the pooled cohort equation. It was coded into the electronic health record. And so in a very simple way, you could sort of get that empirical estimate from the calculator. That I know is being worked on kind of actively for prevent. And so that'll at least get the mechanics of the calculation part done. But then I think to Jessica's exact point, it's the translation of that number, both for the patient, how do they internalize and conceptualize that risk? How do they start to think about their own health and their decisions that they have to make? And how does the provider then kind of translate that number into a care plan that is very much aligned with the aspirations and wishes of the patient? And I think that's the hard work that we still have to work through. Because I think to your point, Dan, maybe to take one step even back, the science has advanced, the guidelines have advanced, LDL control rates have plateaued. And so clearly there's other work that we have to devote and commit ourselves to if we want to take a very important, very comprehensive guideline like the one that just came out, a couple months back, and actually have it have impact for the patients and communities that we're here to serve. That a guideline in and of itself doesn't lead to anything. It's incumbent on all of us as the clinical community, as people that are very much committed to this work, lipids, prevention, optimizing cardiometabolic health, for our patients, to really make that a living document, and then helping our patients, kind of make very important decisions, whether that's primary prevention, whether that's secondary prevention. Yes, I think there's a lot of important discussions that we can and need to have about the translation of the concept, the translation of the document into real decision making.
Yeah.
And just to add, your question about whether primary care docs will use it, I think these are the questions we need to be asking. That's what that's the type of science that we need to be doing. Beyond quantitative science, we need qualitative methods. Focus groups with all clinicians, everyone who's part of the team, patients, to find out what the barriers are, how people perceive the information, because that's, as Nihar was saying, how we move it a step further to reality. And so that's the hard work that absolutely needs to be done to translate the guidelines to practice.
Do you have a gut feeling of whether or not clinicians around the country have an interest in adopting a new risk calculator, and if the tools were there to use it easily?
Yes, I think physicians, they move with the science, and I think that having the Prevent calculator has been out now for a few years, and I think people know it exists and are eager to use it. So I think the questions are, what keeps them from doing so, who's using it, how are they using it.
Yeah, and I guess the background is we do have some colleagues who still refer to the Framingham risk score. So different clinicians may be more or less up to date with the current science and may be frustrated when we roll out new things. And so making it as easy as possible is probably key.
Yeah, Dan, and I think you're right about that. That I think we do have to have some humility and some recognition that like the percentages are slightly different. How you translate a certain numerical estimate into a qualitative expression of risk has been. Now, I think the guideline writers did a very admirable thing trying to align things as much as possible to the paradigm and the framework that we have had and that we've been working within for some time. But you're right. It's a new calculator. Yeah. So the numbers are different, and it's going to take people some time to adjust and to integrate that into their practice. But like Jessica said, I think we will get there, and there's a lot of science that I think can and needs to be done to really figure out how can we facilitate that transition? How can we equip people not only with the guideline but also the kind of adjunctive tools to then translate that guideline into practice.
All right. Well, Nihar, you are an EMR master. So what do you're the clinician who opens up the chart. How do you want that risk calculation to be shared with you when you're the clinician seeing that patient?
Yeah, I think all of us are interacting, more and more in our daily lives in many contexts with all kinds of digital technologies and digital tools. And many of those interactions are incredibly seamless. They're incredibly helpful to us. And the aspiration is that the electronic health record should work in exactly the same way. Many institutions, my own institution, has committed incredible amounts of resources to the adoption of electronic health records. And yet I think we underleverage the tool outside of maybe copying and pasting notes or doing billing. We haven't quite leveraged it for driving quality, for driving, experience for patients and clinicians. And so we've been very much bullish on that concept of how can we use this ubiquitous tool that we've committed lots of resources to, and instead of seeing it as something that inhibits the kind of practice that we want, but really seeing and leveraging it to facilitate the kind of work that we want to do. And so I think to your question, I think that is the kind of work that needs to be done such that the EHR would give a clinician, and at some point, I hope we'll get to this too, something that would be patient-facing as well, that would really activate them, that would educate and inform and empower them in their own decision-making. But on the clinician side, would, in the background, do a calculation of the Prevent risk score, present that information in a way that was meaningful to the clinician, such that it would help enable and facilitate a conversation with a patient, and that they would walk out there from that visit knowing that they are working towards and commensurate with what was in the guideline document. I think it's aspirational. We certainly haven't created that in its idealized state yet, but I think that's the work that we're very much, committed to doing.
All right. Very smart answer. You didn't give us a concrete. Jessica, I'm going to put it to you. What is the chart? What does your screen look like where it gives you that information?
Well,
or danced around it.
That's, there's probably not one answer. I think we need to test these things, right? We need to see, because sometimes we think what sounds like a good idea isn't always the right way to do things. And so I think, and what works for me might not work for someone else. And so I think we need to test different strategies of how to deliver the information, when. Is it before a visit, during a visit, after a visit? Is the more important part sharing it with the patient rather than the clinician? So I think we need to test all these different strategies. So I won't
Nice.
put my nickel down.
No, I really like that answer.
But Dan, I think to very much to Jessica's point, at least our early learnings on this, we know a few things. What doesn't work? What doesn't work is crude, unsophisticated, interruptive alerts that interfere with providers' workflow. Those don't work. We should stop doubling down on developing those kinds of alerts. What might work, and what the science has to guide us, is individualized, tailored alerts that come up at an appropriate time during the clinical encounter, that have embedded ordering capability. So at the push of one button, can actually execute the kinds of things that we want the clinician to do. And I think if we create something like that, then I think we've got a chance to show some incremental benefit. The other things that we've learned is we've kind of gone from a version 1 of a decision support tool around LDL cholesterol management to now a version 2, where we've done some refining and it's gotten more sophisticated. We've included, for example, the provider's name. Dear Dr. Soffer, the patient that you're seeing here is at heightened risk. Here's why they're at heightened risk. And it's pulling things from the medical record. It's pulling the most recent lipid panel, so you don't have to scroll or to a different tab of the EHR to find that information. Here's are the most recent medications that the patient's on. Here's what we suggest that you do. And if you hit accept, it will do all of those things. Now, you can dismiss that alert, you can modify it, you can use it in whatever way might make sense to you. And to Jessica's point, we then have the ability now to track and to learn and to understand what's working, what isn't, who's dismissing, who's accepting, the recommendations, and hopefully with that, conducting additional focus groups with our, frontline clinicians to say, hey, what would you want to see in a version 3? I mean, most of the leading technology companies are doing hundreds of A/B experiments every day on the font, the color, the location on the screen, what it looks like, the content, the phrasing. And yet, if we are committing to doing this type of work, then we have to commit ourselves to being that rigorous and that committed to evidence generation to really think about every piece of what that decision tool kind of looks like.
So you're saying that humans like being treated like humans.
Exactly.
All right.
Yeah.
That's a good take-home message.
Yeah, that's right.
That's great. I'm glad to hear that that's evolving because, the dehumanizing aspects of being a clinician is what I think drives a lot of clinicians out of the clinic.
Oh, I think it's been the leading cause of dissatisfaction amongst our, professional colleagues. Yeah.
Let me put it back into your wheelhouse, a little closer to your wheelhouse, Jessica. In the cardiology space, we're told that there are 2 different risk categories for people with established ASCVD, right? A very high risk category and a high risk category. How much do you pay attention to that?
So I understand the guidelines, the rationale for that distinction in the guidelines and what the guidelines need to do because of the evidence that's available. I do think that making these decisions more complicated in general is a barrier. And I think with the way, the new information that we have, we've talked a lot in this meeting about the Vesalius data, and other data that distinction, is probably not as important anymore. And being able to simplify the guidance, about goals being lower in people who have, who are at high risk or have, atherosclerosis or diabetes, will help with, simplifying the message will help with adoption.
Yeah. Yeah, I would agree. I tend to think of the very high risk category for ASCVD as the default, but in some cases it's not so easy to achieve the goals that you're trying to achieve. And then you have to step back and think, am I okay with less intensive goals here? And then you can use that as a justification based upon the evidence that, hey, maybe I am okay with a less intensive treatment strategy for this individuals. I like that. There's some other groups that are called out in the guideline as targeting for therapy. So our patients who have severe hypercholesterolemia, our adults who have diabetes, of course, and our adult patients who have HIV and chronic kidney disease, stages 3 and 4. Nihar, do you think the uptake and the attention to care for those groups as necessitating pharmacologic LDL lowering therapy are we there, or do we have more work to do?
Yeah, I think there's lots of work to do, and probably for all of the different groups of patients that we're seeing. I think we've got lots of work to do in cardiology. Jessica and I, for secondary prevention, for primary prevention. I think we've got lots of work to do. I think for patients with diabetes, for patients with CKD. I mean, these are some of the most undertreated patients that interact with the healthcare system. And those with HIV and other, I think, kind of related inflammatory conditions. And so, yeah, I guess that's in part why I say this can't be the work of the lipid specialist. This can't just be the work of, one subspecialty. It has to be the work of the entire clinical care team. And patients just want the best care. And they're not worried about, well, this person's going to take care of this and some other person's going to take care of, something else. They just want to know that they're being taken care of. That's what they deserve. That's what they want. And it's our job, I think, to develop systems and empower and engage our colleagues, such that everyone feels comfortable kind of translating the guidelines, which I think has, again, in very important ways, tried to distill science to say, hey, there are some groups that really warrant extra attention, or that we really need to be thinking about very, very clearly. And I think the ones you said are really important ones.
Do you think this is mostly a rhetorical question, but do you think it's possible to provide educational materials, guidelines for clinicians without EMR stratification of these features that necessitate treatment within the EMR, or can you just educate the clinicians and let them do the right thing? I think I know the answer to this. But
yeah, I think there's a very important role to play for education. I will say this is a space where NLA has done really important work with the simplified series. Yeah. And so we're going to have a new version of the LDL simplified document, which I think is meant to really distill a very comprehensive document into the most essential messages that are practice ready tomorrow. And I think clinicians can take that and feel comfortable that, hey, having read a front and back of a, kind of a worksheet, that they've really captured the most important kind of takeaways from a very comprehensive document, which of course is available for them to review. Now, complementary to that, would it be nice to have other elements in the ecosystem of care delivery that also can serve as an echo chamber and to hardwire, process and give people feedback and give them, real-time information? Yeah, that would all be great. But every practice setting, like Jess was saying, is unique. Everyone has their own constraints. Everyone has their own infrastructure. Everyone has their own, sort of capability, if you will. But I think there's always a role, I think, for really, high yield education, to connect with the clinical community.
Thanks for bringing up the simplified series that the NLA has embarked on. Jessica, I have a strategic question for you. Do you think that the educational material can be just for example, an LDL cholesterol simplified, and it's for clinicians who are not lipid specialists, or would we need something like that plus a separate educational piece for patients? Or can it be just a single document that is useful for clinicians who aren't lipid specialists and their patients?
I think that patient-facing material should be a priority. I think more and more, even if we don't create it, people are still, going out and getting information on their own. So I think we ought to be involved with the information that people see. And I think it's, even more important that people get their information from reputable sources. So absolutely, I think a critical part is, being part of the conversation with, translating the guidelines, to the sources people are getting, and we should involve patients with, how they want to receive that information.
A couple technical questions. So some things that were in the guidelines spoke to how we measure LDL cholesterol, or how we calculate LDL cholesterol, and whether we should be using non-HDL cholesterol, and then when to use ApoB. At your institution, Jessica, what LDL cholesterol calculation are you getting at your institution?
So we use, outside labs, and we're very much guideline concordant.
Yeah.
I will say, I think another barrier that's addressed in the guideline, and this isn't new, is just the non-fasting cholesterol and the value of non-fasting cholesterol. And it's fascinating to me. This is like such a prime example of the long lag with respect to, guidance and what's happening in practice. That guidance has been there for many years, and still, every day people tell me I can't have labs done because I'm not fasting, or people go to an outside lab and get turned away because they're not fasting, and that's been in there for a long time now. And so I think that's an example where we still need to educate right beyond our community, patients especially, on the value of non-fasting lipid profiles.
Yeah.
Just getting back to measurement. Something so simple.
Off the record, I will tell you that I have told patients to simply lie to the phlebotomist. Yeah, it's easier than trying to explain to them that it can be a non-fasting profile. Yep. Non-HDL cholesterol is not always reported on the lab report. Do you care about that, Nihar?
I will say for most patients in most clinical interactions, I'm primarily looking at the LDL.
Yeah.
And yes, in that subset of patients, or in that clinical circumstance, yes, I want an ApoB, and then I might, specifically get that. But for most patients, I think a standard lipid panel, fasting or non-fasting, gets us most of the way there. And if we focus on LDL, we will be much, much better off than we are now. I think there's a role and there's an importance for nuance and complexity. Of course, we want to be true to the science. And I think the guidelines have really, really done that in a very important way. I think when it comes to the translation of those guidelines into routine daily clinical practice, I think there's an importance for simplicity and trying to get people to, get a long way there.
Great. So that being said, I'm going to make it more complicated right now.
Yeah.
So Jessica just told us that LDL cholesterol is king, but the guidelines also suggested that we test lipoprotein a in everyone. How are we doing at that?
So I think more and more people are getting LPA tested. At least that's my sense. There's definitely greater awareness, at meetings and, in the media. So I think that I'm optimistic. I think a challenge will be, it sounds easy. Again, the implementation of that, have your LPA checked, but people get care in many different places at over many different years, and just finding that single value and making sure that it's there. It, as Nihar was saying, that should be at the fingertips and easy to find, and it's not always so easy to find. So I think I think that the word is out on LPA.
Yeah.
Right. What do you think?
Yeah, I think so too. I mean, I think if we try and take an analogy, and we say we've been talking about LDL for decades. The science on LDL has been there for decades. The clinical trials, the guidelines, and even today, it's about 1 in 2 patients that have an LDL test performed, and it's far fewer that know what their LDL result actually is. We're in maybe the first or second inning of the LPA story. And so I think you're right. We're clearly on an upswing in terms of testing. And I think that's good and important. I think the guidelines have rightfully talked about the importance of LPA as an emerging marker and risk factor. But it's also going to be one where this can't just be the work of a subset of providers in the prevention clinic or in the lipid clinic. It has to be in primary care and family practice and, endocrinology, and everyone has to come together to do this kind of screening and to do this kind of, this kind of effort. And so I think we will get there. But it's going to be, it'll have the same challenges that others have had.
I already offered the pro tip of lying to your phlebotomist about fasting. The pro tip about the LPA, rather than having to scan back through the chart to see if it was ever tested, is my pro tip is when you do the test, if it's normal, incorporate that into your lipid diagnosis. So this patient has hypercholesterolemia, normal LPA, or add in another diagnostic code for elevated lipoprotein little a, and specify in that code that it was 2 times upper limit of normal, 5 times upper limit of normal, whatever the number. So that's the other pro tip.
Oh, that's nice. Yeah.
Yes.
Not all about lying.
Yeah.
Problem list.
The NLA is a multidisciplinary group, especially one of our most important constituents are the dietitians in our group. And there were several recommendations to access dietitian care and dietitian access. Do you have a dietitian in your program, Jessica?
I'm able to refer. I have access. Yes, absolutely. And it's a really, I encourage every patient who's coming to see me for dyslipidemia to see a nutritionist or a dietitian. Yes.
Some challenges in getting them to do that, or
Yes, I think, like a lot of other things, it's sometimes people think they know what to do. That's often a refrain that you hear. And I'll quote my colleague, Dr. Underberg, said something he likes to say is, you know what to do, but you need help with how to do it.
Yeah.
And I emphasize to patients the data showing that people who work, who do medical nutritional therapy do better than people who don't, and what the evidence says, and the practical support that someone, that they can get. So I think, with that information, people are usually more open-minded.
Yeah. I think I'm not going to go down that path talking about that too much. I think there's some real structural limitations to widespread access, but making use of dietitian is an important part of what we do. I do want to end on thinking about how we monitor our patients. This was not a new recommendation in this guideline. You go back to at least the 2013 guideline, which people complained about because there weren't any goals embedded, but there were very clear instructions on regular monitoring, follow-up, and the approach to management when you're not achieving what you think you should. So Nihar, again, you're very much always thinking about systems and how to. It's hard to improve on that at the individual level. Are there some systems ways to improve upon that?
It's a great question. I will tell you one of the things, because under testing is still a foundational challenge in this space, despite all the recommendations, despite the simplicity of fasting and non-fasting, and don't worry about it, just get it done. It doesn't matter. It's sobering to think about how few patients actually get their lipids tested. And so I do hope that at some point there'll be maybe a future state where with whatever technology, and certainly don't want to litigate, all of that, in the podcast, but can people have that at the time of their visit, and that we should think about LDL cholesterol as a vital sign, just like a blood pressure. Just like an EKG, like when we have a clinical encounter. I would argue that as important as a blood pressure is for that clinical visit and what we're going to decide, having an LDL cholesterol available to me at that visit in real time is essential. And so what system can be put in place? How do we bring that to bear, to bring that to fruition? I think we're very much interested in exploring all different kinds of opportunities for kind of, making that happen. Because the stakes are really high. It doesn't get more serious than the kinds of things that we're talking about now. And the urgency is real. And we've got more and more therapies that are being brought to bear in this space. And yet maybe I'll end where I opened a little bit, and yet control rates are essentially unchanged. And so we've got to be able and ready to do something differently, to be creative and to innovate in the space if we expect the future to be different than, what we've done before.
Yeah, I'm really looking forward to seeing the next round of epidemiologic monitoring.
Yeah.
We're already seeing the needle move with regards to weight loss from GLP-1 and other incretin therapy. And so like in real time, we're seeing that. And the adoption of more intensive LDL lowering therapies, especially PCSK9 inhibitors, I think I'm starting to sense an uptick that even in the short time since the guideline has been released, an uptick. And so I'm looking forward to seeing results from the clinical epi people to show us what's actually happening in real time. So I think we could have gone through the entire guideline manuscript line for line and say, all right, well, what are the challenges of implementing this? And, 7 or 8 days later, we might have gotten past the first page. But I think we hit on some key highlights, some parts of the guideline that as clinicians and as people who think about systems that we think are important. And I'll give you each a chance to, if you want to throw in one more piece that you wanted to throw in as a specific to implementation challenges or strategies that you want to throw at us. Jessica, I'll start with you.
I'm optimistic, so I won't talk about a challenge, but I'll talk about what I think is a facilitator. I think this has been a great meeting here at NLA in Chicago with a great turnout and a lot of enthusiasm. And so I'm optimistic that our field is growing, the number of people interested in prevention and keeping people healthy is growing, and that will really help spur change.
Yeah, I think that's incredibly well said, and I would certainly echo all of those sentiments. I think when we get back to our practices on Monday, I think what we have to confront is the easiest thing to do is to do nothing and to leave things unchanged. And for a patient sitting in front of you, the stakes are high. You deciding not to initiate something, to intensify a therapy, or to add a non-statin, medication to further lower their LDL cholesterol, commensurate with what the guidelines are asking us to do. That there's too many events, and there's too many events that can be prevented. And so I would say, let's continue to build on this enthusiasm, to build on the sense of community that we have around lipids and prevention, and the excitement we have for the new therapies that are now available, and really deliver for the patients and communities that we're here to serve.
Great. Thank you both. I could talk to you all day, and I can't wait to see you downstairs at the meeting. And thank you so much for your insights on implementation challenges and insights into implementation strategies relating to the guideline.
Thank you for having me.